There were a couple of studies around depression in patients with cardiovascular disease. The first was named CODIACS, and it's a study of screening for depression in patients with acute coronary syndromes. The investigators enrolled 1,500 patients and did not screen one group of 500 patients. Screened 500 patients and notified them if they indeed had depressive symptoms, and then finally screened patients and treated those patients with depressive symptoms in the third arm. So 3 different approaches to patients with potential depression shortly after acute coronary syndrome. What the investigators found was, number one, that the incidence of depression, or the prevalence, I should say, of depression in their patient cohort was less than they expected. It was only about 7% of the patients who underwent screening. So about 38 patients in the the screen and treat arm, and about the same number in the treat and inform arm. They found no impact of the screening strategy on outcomes, including health-related quality of life and other parameters that you might expect would benefit from depression treatment. So that was a negative study, but one that's important to publish all the same, or to present all the same, because it is a study of treatment strategies. The second was called the Hopeful Heart study, which enrolled about 630 patients, in this case with systolic heart failure, who were known to have depression. And in this trial, patients either received usual care or received enhanced care for heart failure with a multidisciplinary approach to heart failure care. And in the third arm, what was called blended care, which is not only treatment for heart failure, but treatment for depression, specifically with the contributions of psychiatrists and other mental health professionals. In this case, they found improvements in the mental component, the mental health component of the SF-12, which is the health-related quality of life scale, as well as the PROMIS scale with respect to depressive symptoms. So this was a positive study where this enhanced blended care model was effective at improving depressive symptoms. Interestingly, there was no impact on heart failure symptoms, which you might expect in a treatment program that's directed at depressive symptoms. The take home from these studies is, I think, that number one, it's important to be looking at comorbidities that interact with cardiovascular disease like depression. Depression has a very important impact on outcomes in patients with cardiovascular disease, and addressing this comorbidity, I think, is important. The second is these were relatively pragmatic trials, so studies of strategies of care, not just one pill versus another, but comprehensive approaches to the care of depression. I think they also highlight some of the challenges of conducting these kind of studies. In the case of the first study, the negative study, there was a low rate of depression in the cohort, and as a result, that may have resulted in a study that was underpowered to assess for an impact of these sorts of interventions. So 2 studies, both different types of outcomes, different patient populations, but I think some common understanding that we can generate as a result of seeing the results of these studies.